Welcome everybody to the monthly University of Miami Cerebrovascular and Skull Base Symposium on the third Thursday of every month. This is, believe it or not, session 41. Today on December 16, I'll introduce my wonderful speakers at the end of this brief introduction. This is the journey we've been through. You can see we are at the end of the year here, and we're still trying to figure out if we change the format for 2022, but we certainly will continue to go strong, and I will let you know what the new format and the schedule is for 2022. We're waiting for inspiration over the holiday season to see if we continue exactly as is, or if we will change the format in a different way. As every month, our skull-based cerebrovascular fellow, David Altschuler, will join the panel, as well as our PG3, Eva Wu, to show a couple of cases for panel discussion. I'm Jacques Morcos, the co-chair of the department here, and director of vascular and skull base. We have with us today my partner, Carolina Benjamin, co-director of the course. By now, you know all my partners who have been instrumental in putting these courses together, Carolina, Mike Ivan, and Bobby Stark. I know that many of you always attend them, so you'll find it redundant that I introduce people every time, but you know we always have new people who join us, and thank you for joining us every month. As you know, we were doing pediatric sessions as well. Our partners in pediatrics on Mondays. They will come back later. The Miami Global Brain Tumor Symposium that Mike Ivan puts together the first Wednesday of every month. Again, encourage you, if you don't know it, to join us. It's a fantastic series of speakers, as you can see from the last one in October. Many thanks for the team here at the University of Miami that makes these Symposia possible, and particularly Ignacio Escalona, who runs all the technical aspects of these things. These are the various links that get you to our website, where you can actually watch all the previous sessions. They're all recorded. They're all on our YouTube channel. It's actually quite a library now of spectacular series of lectures by speakers from all over the world, not just for this symposium, but also for the Wednesday symposium and the pediatric symposium and so forth. Twitter account, Instagram accounts, feel free to reach out. You know the format of this symposium. We always have 4 speakers, 20 minutes each. And the most important part is a Q&A at the end. So please put your questions in the Q&A box, and we will be sure to address them. And now, again, a brief introduction of tonight's speakers in the order in which they will speak. It is my immense pleasure to welcome again Judy Wang, who's professor and vice chair and program director, as well as director of Cerebrovascular, co-director of cranioplasty, Chiari and trigeminal neuralgia programs and Johns Hopkins in Baltimore. And also she is a member of our spectacular board of neurosurgery. And Judy, of course, is a world expert in cerebrovascular particularly, and Judy is wonderful to have her tonight. Second is who I call a younger brother to me, and who used to be my resident many moons ago and has gone on to be a spectacular star, Muhammad Ali Aziz Sultan. Most of us know him as Ali, is associate professor and very soon professor of neurosurgery and radiology at the Brigham in Boston. He's a chief of vascular and endovascular, co-director of the Comprehensive Stroke Center. And Ali and I go back a long way, and it's any excuse I have to invite him so I can see his lovely face, I do it. And of course, to listen to his very thoughtful remarks that he usually has about any topic that he tackles. Third, Clemens Schirmer, unfortunately, his flight had changed, so he cannot be with us in person, but he was kind enough to send me a pre-recorded 20-minute presentation. And Clemens is currently the chair of the CV section. He is director of the Comprehensive Stroke Center of the large Geisinger Health System in Wilkes-Barre, Pennsylvania. And I know that his talk will be spectacular. I've already listened to it myself. Last but not least, everybody know her as Stav, but I don't know why people perhaps have a speech impediment or something, but she has a lovely name and her name is Greek and is Stavropoula Joumakaris. She's professor of neurosurgery, director of Endovascular and Cerebrovascular Fellowship. She is associate program director at Jefferson with my good friend there, and she's in Philly, Pennsylvania, and always gives fantastic and very thoughtful presentations. So you can see a fantastic panel tonight. And I'd like to wish everybody happy holidays, any holiday that you celebrate, whether it's Christmas or Kwanzaa, or of course, Happy New Year. And I will see you all in 2022. And now I invite Judy to share her screen, unmute the microphone, and start her presentation.
Really an honor to be here in my old home. I went from Miami to one of the leading institutions in the world, a place where Harvey Cushing walked the halls and so forth. And I got there because I was my mentorship. The people that trained me were the biggest hearted people in neurosurgery. Roberto Harros, Spetzler, and Jacques Morcos, as cute as he is. I was at a stage where we were caught between this battle of endovascular and open vascular, and a number of us were caught in this, and I thought it was interesting to learn from both and try to combine the two different disciplines in whichever way that we could. And with that, I found a little niche for myself, and came to Boston, developed ORs, talked about different techniques that I had learned from Dr. Morcos and Dr. Harros and so forth, and really started to develop a group and a network of wonderful people that helped me. That's just a small part of my identity. The biggest part of my identity is this. I'm from Afghanistan. I was a child that was born there and raised there. And this is one of the first few paintings I had made, and this was in Germany. It's after the 40-year war started, and it's something that keeps repeating itself. A small, beautiful country in constant conflict with superpowers, the English, the Russians, us. That's me the day before we escaped in the back of a Toyota pickup truck. Made it eventually from Afghanistan to Pakistan to Germany, the whole refugee thing, completely disorganized upbringing, parents working multiple jobs. I really started to identify who I was by mentorship from these two, Roberto Harros and Jacques Morcos, who took me under their wing and gave me structure, direction, unwavering love. And it built who I am now. Gave me confidence that I never had growing up, and it was one of the best programs in the world. I'm so proud of that program and where it came from. As soon as residency finished, I went back to this yearning thing in my heart, and that was going back to Afghanistan that was still in conflict. And I went around the country and toured different places just without telling anybody. My aunt was the minister of health at the time, and took me to this hospital and that hospital and the glass bridge and all of those things, but these hospitals were empty. So I decided to go on my own and to some county hospital, and actually found the people that I wanted to find, not the politicians. And I found this one guy there who I didn't even know if they were neurosurgeons. I just said, I want to come here and help out. I had going through some tough times, and I was trying to rediscover who I am. And we started working together. Over years, I would go back, get instruments from here, take them there, and they were very, very good. There's actually 74 neurosurgeons in Afghanistan. And slowly over the years, he started building a residency program. This is one of the young men who's presenting in the ER. He actually lived in the hospital. He was a resident. He was presenting this epidural hematoma on a young 16-year-old boy who had to, his brother, that's his nurse, his brother, who's 18, brought him to the hospital, put him in a cab, took him across town. They gouged him for 3 months of salary to get a CAT scan. The CAT scan had to go to Pakistan, just took the films and brought him back because he was herniating. We operated on them. They operated on him with drill and so forth, and he lived, and his brother stood by his bedside day and night taking care of him. The program over the years built, and more residents were being trained around the country. It's all this man in the middle that did that. And within time, people came to the house where I was staying with different problems that I couldn't help. I'm asking him, where does it hurt? And whether she'd give me a kiss. Everybody loves their children like we do, right? They're not any different. They don't feel any different than you and I do about our loved ones. So in Boston, I was fortunate enough to finally get some real education and sort of pay attention in school and learn things about system dynamics and how everything is interrelated and how not to judge the final product and how to see all the things and the math behind that of how events happen and how you can tweak things in order to get the final result. And it can apply to almost anything. And for us, we've used it in the stroke system around here and in order to figure out, you know, how patients get and how access happens and how you can change workflow from push to pull systems. And it's been really eye-opening to see medicine from a different perspective. We started this work to see if there could be some similarities that we're doing with stroke work here applied to Afghanistan. So working with the Harvard program for global surgery led by Key Park, we started to map out Afghanistan and which regions had what populations and so who had access to healthcare and within what time period. And we started to, this is during COVID, because I got bored on the weeks that I was hiding at home instead of working. And so we put together a group of very, very special people from Japan to Boston to George Washington to Afghanistan to Pakistan. This gentleman on the right has a cell phone in Afghanistan, but no electricity. So we started to gather people to talk about opening up education and sort of really understanding capacity of neurosurgery within the country. And we started to map out where the public hospitals were that served the poorest of the poor. And we started to figure out where in the country 95% of the population had access to. The government fell in the midst of this, and there was an urgent need for equipment. And Afghanistan is second to Syria, the highest rate of death from trauma, especially in the 40 and under age. And these are text messages from residents through WhatsApp and instruments and so forth. So we had built this pipeline of Boston, World Federation of Neurosurgery, Germany, Northwestern University in Pakistan, Afghanistan, all academic neurosurgeons. We raised $60,000 worth of money here quickly as everybody was fleeing the country and the country is getting locked down. This $60,000 translated to $700,000 worth of equipment acquired through the Majid Sami program with the World Federation of Neurosurgery through a wonderful man, Miguel Arias, who helped us. The fundraising also brought special people to me. This is Dr. James Muller. He's a Nobel Prize guy whose office is right there. He's a cardiologist that started this organization of Physicians Against Nuclear Weapons, which brought the United States and Russia together during the Cold War. And that organization got a Nobel Prize. Very, very, very special man. The instruments, while the country is getting locked down, went, like I said, from Germany to Pakistan, through the border, through pharmaceuticals, things to all of these different regions, and actually made it into the hands of people that were actually operating. This is one side of the country. This is another side of the country. And what it did was it started to solidify those relationships, that we were there to help as opposed to take, which is what happens with Afghanistan. And we started to create educational opportunities during now. This is like a month ago at the Japanese, Dr. Kato's organization, ACNS. This is a woman neurosurgeon presenting on penetrating gunshot injuries, a woman neurosurgeon. The things that you hear are sound bites sometimes, and we don't get correct information here. The next phase of this project is to now bring all of these 10 different hospitals online. We're working with a group to put fiber optic 5G technology here. First, it's for communication. Next step will be for telemedicine. And then maybe beyond that, it'll be for the things that are very, very, very special in the next thing. In endovascular and vascular, we've advanced instruments with advanced diseases. Now we're starting to explore processes. This is our new device, AI software to understand and diagnose. Imagine that boy who almost died herniated. This software and software like this, imagine what it can do in the future in these types of places where it gets automated and replaced without having human capital to do that. Or this, robotics coming down the line that Stavros and her group, Stav and her group are working with, where you're actually controlling catheters from remote areas. Outside the room, she does it now. Maybe you do it from outside the state. Maybe you do it from outside the country. And maybe instead of using the same technology to drone and bomb people, that we can actually lead with a humanitarian effort. And with the same flick of the hand, you can help people instead of hurting people. It's a pipe dream. It's a pipe dream. But for somebody like me, neurosurgery was pipe dream. I think mapping the country, understanding healthcare system, taking in a niche through neurosurgery, even though it's a small pie, the processes look the same. The way a neurosurgical patient gets emergency care is the same way a trauma victim gets care, is the same way a young woman gets care. It's the same way in a country that has the highest infant mortality rate, where the future seeds of the country are dying, they get care. So maybe it unlocks a new way of thinking about things. This is the last slide. And it's the slide that I learned at school. It's the social progress index. every society, the basic pillars, as beautiful as democracy is, as beautiful as education is, the four basic needs are food, shelter, healthcare, and safety. It's the basic survival mechanism. And we are privileged to be at a corner of how societies function. And maybe we can solve these problems so that for our children, we have a better future. And for the children of that country, there's an opportunity to grow and maybe become somebody. Thank you.
Well, Ali, this is, I mean, I knew you were working on this. This is spectacular. And of course, it's your next big chapter in your life of passion that you've always led. And I commend you for all these efforts. And I am sure so many hurdles on the way. If we spoke to you, if we speak to you in 6 months, what realistically, what do you think would be achieved 6 months from now through all your efforts and your colleagues?
Dr. Morcos, already there are scholarships given to women and passes to go to Spain, to go to Turkey. Already we're presenting at the ACNS, and there's collateral education. I'm hoping that there will be a bigger form of communication, and I'm hoping that the world strategy changes, because right now, because of all the things that are politically related, there's sanctions in the country. And when you put sanctions, children are starving, poverty is at an all-time high, and it's going to be one of the biggest humanitarian crises of our time, right? Yeah. So a humanitarian-led effort, even if it's a small niche, even if it's grassroots, maybe shows people that there's a different way of engaging these places. Instead of engaging with fear of terrorism, that you actually engage with a humanitarian effort. I don't know. Like I said, it's a pipe dream. Yeah. I'm exploring, and these talks I give to keep myself accountable so that I stick to my word.
Have you talked to Bassant Mishra, the new chair of the WFNS Foundation? He replaced Miguel Arayez and, of course, Nelson Oyeshiko, who's a chair of the WFNS, the president.
I spoke with Dr. Oyeshiko. I haven't spoken to Dr. Mishra yet.
Yeah, you should. I mean, he, anyway, but we can talk offline. And any of this is probably the right time to ask Ali. I mean, the rest of the talks are very different, of course. Any of my co-panelists or co-director want to engage Ali with any questions, or this is obviously very dear to his heart? As no, I think you grabbed us from the heart. Bobby, you want to say something?
No, I was just going to say great work. I mean, I didn't have any questions, but it's obviously a monumental effort, and congratulations on the start.
Thank you. Very proud of the work you're doing there. Hear wonderful things about you. Thank you for that comment.
Thanks, Ali.
Oh, hold on. I think I see Q&As. Okay. Dr. Ahmad Atasi, Ali says, Ali, wonderful, very thoughtful. What are your thoughts about endovascular robotics? You want to?
I've remotely played with it because it was developed back here, but the real expert is Stavro, and maybe she could sort of take that.
We'll ask her a little later in the talk. Okay. And then Estefani Nicole Fuentes Roca wants to ask you, thank you, congratulations on your very touching lecture. Great, enjoyed it a lot. She wants to ask if there are scholarships for residency in neurosurgery available. She's from Bolivia. Estefani, not for residency, but there are for fellowships, and I'll probably answer you later offline, not to take too much time from the speakers. I'll send you later a chat answer. Okay. Well, you started it very well for us, Ali. You put us
A little heavy.
What? What's
A
that?
little heavy, but
I wouldn't expect anything less from you, but that's okay. But it's okay. You know, neurosurgery is not just mind, you know. Neurosurgeons who have no heart are not good doctors, but we know that already. Okay, Judy, let's see if you have fixed your technical issues.
Let me try again. So Ali, I just wanted to commend you. That's amazing what you shared with us. The work that you did is just incredible and very inspiring for all of us. You know, just congratulations on that, and obviously very thought-provoking. And
Thank you so much.
one of the best talks I've heard in a long time.
Thank you so much.
Judy, before you start, Ali, there are many more questions coming to you on the chat. Feel free to enter the Q&A and just answer them individually, so we don't, you know. Thank you.
So
Judy.
hopefully I fix my epic technical errors.
You did.
Okay, great. Too many windows open. So, all right. So I'm going to switch gears a little bit and sort of reflect upon clinical decision-making with AVM treatment, especially after ARUBA. And, you know, of course, I have to start by thanking actually my one of my former fellows and my current fellow, James and Shahab. James is from Lebanon and Shahab is actually from Iran, and you know, have done spectacular work over the years. And so they helped me with these slides. And you know, the reason that my talk always starts with clinical scenarios is because that's sort of what we're here for, right? Meaning as neurosurgeons, we're really about figuring out what's the best way to take care of our patients. And I am always reminded by these three young women who all are, you know, in their early 20s, who presented with very different AVMs and had very different courses. And the ultimate question is, how do you figure out what's the best way to serve them, to take care of them for their problem? And you know, the first one just had headaches when she was studying, and she thought she was super stressed, and ultimately got an imaging study, and it shows, you know, she's got this premotor and you know, motor AVM. The next one was a nurse who was working actually on one of the hospital's unit in neurology and had a seizure at work. And then the third, unfortunately, came in on call and was very, very sick with a large ICH, and ultimately found to have an AVM. So to try to answer these questions, you know, there's certain things that, you know, beginning learners always familiarize themselves with, sort of what's the incidence of AVMs. Yes, it's a rare disease. Yes, it's you know, can be diagnosed with an ICH, and it usually happens early on in one's life. And then other presentations are seizures and headaches and neurologic deficits, right? So we know the basic stuff. We also know really from early on, the teaching is that the risk of hemorrhage is initially only about 2 to 3% per year, but that the mortality is the problem, that there's a high rate of mortality, nearly a third, and then about 10 to 20% of people after a hemorrhage have a long-term disability. And then furthermore, if you have one bleed, you're more likely to have a second bleed. The quick and easy way to calculate the risk of hemorrhage over one's lifetime, when there's a patient sitting in front of you in the office, is to use the simple formula of 105 minus the age, and that you can get an estimation of what's their lifetime risk. And then listed in the table below are the sort of classic papers that talk about natural history, but they are all mostly retrospective, and that's where the 2 to 4% comes from. So ARUBA was published in 2014, and that really changed how different practitioners looked at AVMs. And so this really, the main conclusions were that if you treated AVMs with interventional therapy, you had 3 times the rate of death and neurologic disability than if you compared it to medical management alone. And that's shown by the Kaplan-Meier curve, where, you know, the blue is much higher than the red. And that sort of threw everybody for a loop, and there was lots written about it and so forth. And most recently into 2020, there's actually a sort of the final ARUBA results that were published. And this follows patients out to 50 months. And they concluded, you see with the similar Kaplan-Meier curve, where the blue of interventional therapy is associated with a lot more stroke or death than the red line that depicts medical management, even at the long-term period. And this is even though the people who were at risk are much lower than in the first publication, nevertheless, the concluding comments from the authors is that there's still a lot of people who suffer from interventional therapy. So it's important to have an overview of what ARUBA has done in terms of spurring and inspiring a lot of different publications that many authors have come up with in utilizing ARUBA eligible patients to look at what happens to patients who undergo various treatment modalities. And here I'm just listing all the different publications. This is just a sampling of publications where people look at ARUBA eligible patients who undergo microsurgery, or ARUBA eligible patients who undergo embolization alone, and those who undergo radiosurgery. I'll just note that in the embolization only group, the risk of complication or stroke or death is higher, you see, than the ones who undergo microsurgery alone or radiosurgery alone. And same thing is borne out for radiosurgery and multimodal therapy. So basically, there's lots and lots of authors, investigators who have demonstrated much better results in looking at their experience in treating ARUBA eligible patients using carefully selected modalities that are appropriate. So in looking through the literature, I'll just point out this systematic review and meta-analysis by Bijam et al. That actually predated ARUBA. And they were the first to actually make very clear that there are varying rates of case fatality and long-term risk of hemorrhage and complications, and also in obliteration rates after different types of interventions, so that all interventions are not the same. That's not surprising to any of us. But the authors of ARUBA lumped everything together, lumped embolization only with microsurgery, lumped stereotactic radiosurgery with multimodal treatment. So that's not exactly a fair way of looking at things. And that was actually published in JAMA in 2011, where the meta-analysis actually included nearly 14,000 patients in this group. Next, I'll present this paper, who I think the first author is your PGY3 resident, Eva Wu, is that her name? So is that right? I think it is the same, I believe it's the same Eva, but so this is from Babu Welsh, and they looked at a review of what are the outcomes after embolization of brain AVMs with the intent to cure. And you can see that they break down the complications by complication type, whether it's a hemorrhage, ischemia, seizures, temporary focal neurologic deficit, or permanent. And you can see the numbers highlighted below. And this goes to show you that the risk of embolization is not trivial and definitely significant when the intention is to cure. And they do conclude that cure via embolization is more of a bonus than expected. Other authors, so Nick Bambakidis and his group, also did systematic reviews and meta-analysis, and they showed this in this very interesting paper of comparing stereotactic radiosurgery with and without pre-radiosurgery embolization. And they found that there's lower obliteration rates when you combine embolization and SRS versus SRS alone. Moving on to other authors, this is the same type of finding. Bobby Stark was on this, back in the day, and Jason Sheehan is the senior author on this, and also showing that obliteration rates are lower after radiosurgery if it is preceded by embolization. So here I'm summarizing other meta-analyses that are very revealing, and the one on the left comes out of China, where they showed also that obliteration rate on angiogram, so not just other non-invasive imaging, but on angiogram was definitely lower when you combine radiosurgery and embolization. Others showed that with this combined treatment, that the rehemorrhage rate at 3 years was not very different. And furthermore, the rate of neurologic deficit was also not very different, sort of leading one to conclude that embolization preceding radiosurgery may not be the best option. So our colleagues in the Netherlands recently put this out, which I think is a fantastic commentary. It's published in Stroke earlier this year, talking about ARUBA and sort of how to approach the thinking behind unruptured AVMs, and indicating how that's changed. And they had excellent comments, which I'll just briefly summarize, that are shown here. And basically, with this type of analysis, they're basically showing that if you look at publications by other authors and prior experience with microsurgery, depicted on the top left, with endovascular, with stereotactic radiosurgery, that the risk of a problem is much lower than what ARUBA demonstrates. So that basically the results from the ARUBA investigators are really not comparable to what exists published by other surgeons. And because of that, it really boils down to that ARUBA was an analysis of decision-making, not of the intervention, right? Because it was really just lumping together all interventions, didn't have any regard for what kind of modality people were put through. And it really was just a decision-making analysis, not a analysis really honing in on the success of the intervention. So because other investigators have definitely shown that there's a potential to achieve good outcomes, how do you risk stratify patients on a case-by-case basis? So one can use grading systems and risk scores, such as Spetzler-Martin that everybody knows. You can supplement that with the Lawton scale that takes into consideration age and diffuseness. And then you can combine that with the Spetzler-Ponce classification to sort of have a class A, which is the grade 1 and 2s, the class B, which is the grade 3s, and then the class C with the 4 and 5, which basically nobody should intervene on. So this demonstrates that the risk of hemorrhage has been studied exhaustively by other authors, that each of these numbers represents a publication, and various factors have been implicated, such as size and deep venous drainage and feeding artery aneurysm and so forth. And there's a lot of controversy because you see how the columns of numbers, there's all these numbers on the left that basically show that there is a significance with these factors. And then there's also numbers on the right where it shows that these factors don't make any difference. And so there is some heterogeneity. So we proposed a scoring system to try to predict the risk of hemorrhage in patients. And we looked at our cohort of 755 patients. We split them into a training data set, into a validation data set, and did univariable analysis followed by the multivariable. We did the model building, the ROC analysis, and then validated the model back with the entire cohort. And we call this the red AVM score. And I'll just go through that quickly. So we took these characteristics and basically did the univariable analysis and picked out that these were the significant factors: race, nidus size, location, number of feeders, and venous drainage. We then did this analysis, and you see how nidus size with the multivariable analysis does not have statistical significance. However, because nidus size is so important in the literature, we forced it into the model. So then we show here that the area under the curve for the training data set is hovers around 0.7, which is very similar to the validation data set. And for context, the area under the curve for the Spetzler-Martin grading score is about 0.66. And then in a field outside of neurosurgery for the Has-Bled score, which is used to predict bleeding in AFib, their area under the curve is 0.72. So our model has a decent comparability. So when we use the complete data set, this is what we get. The acronym RED AVM stands for these factors. So R is race, and we weight it double because the beta coefficient is twice as high as the other factors. And so race, then ED is exclusive deep location, A is for AVM size, small versus large, V is for venous drainage, whether it's exclusive deep versus other, and then M is for monoarterial feeding. And you can see the block score here that for every incremental increase in the AVM score, the predicted probability of hemorrhage goes up by incrementally by about 10. And so there's this stepwise increase and starts from a baseline risk of about 16%, and there's no overlap in the predicted risk. So how do we apply that? So here's an example of a young lady who is white, and she presented with migraines and a right visual field aura. If we apply the Spetzler-Martin grading score, she is given a pretty high grade 4 because of the size being big and eloquence. And then the Spetzler-Ponce class is C. If we add the supplementary score from Lawton, it also is a supplementary grade 4. So this is a high grade AVM basically. And if we apply the RED AVM calculator and look at the factors, the anatomical factors, we come up with the RED AVM score of 0, which means that her risk of hemorrhage is 16%. So when you combine a high grade in terms of treatment and lower risk of lifetime hemorrhage, it is reasonable to consider a more conservative approach. And that's what happened in her. She got migraine medications and she's actually doing quite well, and recently married, I believe. Alternatively, if we apply this RED AVM score to a young man who's Black, presented with severe headaches and vomiting, if you use the Spetzler-Martin scoring system, he gets a grade 3. He's Spetzler-Ponce class B. With the supplementary, he's grade 3, so sort of intermediate grade. And then if you apply the RED AVM calculator and take into account that he's a non-white race, has a it's not a deep location, it's a small AVM, it's exclusively deep. His risk of hemorrhage is 42%. So he's a reasonable candidate for treatment, and indeed he underwent resection. So applying this scoring system to the 3 young women that we started with, you can see that in the student who was stressed out from her studying, her risk of hemorrhage is 16%. So she was managed with radiosurgery at first. And then the 25-year-old nurse, she comes up with a risk of hemorrhage of 54%. She was treated with resection. And then unfortunately, the demonstration that this predictive score has some validity comes from this 23-year-old who presented unresponsive and was a mortality. Using the RED AVM scoring system, it actually is 58% risk of hemorrhage. So this RED AVM score has been externally validated by Clemens and his colleague Christoph Grissenauer. They applied this scoring system to patients at their institution, and you can see the graphs here that the distribution of the patients by score follows a similar pattern, and then the proportion with the rupture also follows a very similar pattern. The bar graphs are pretty similar. And then the area under the curve also is pretty similar. So we're happy to see that there is some external validation. So in conclusion, the curative embolization of AVMs should be considered an unanticipated benefit of such therapy rather than a goal. Second, embolization prior to SRS decreases the rate of AVM obliteration without significant effects on post-op complications and mortality. And so therefore, embolization should be performed only after weighing the merits of partial nidal reduction and the risks of multimodality treatment, where the probability may be lower of obliteration. And lastly, the RED AVM score represents a risk stratification tool that demonstrates some promise in the prediction of natural history in a real world clinical setting. And because there's this growing emphasis on judicious patient selection for AVM treatment, the score complements other grading systems that primarily assess the procedural risk, such as the Spencer-Martin grade and the supplementary Lawton scale. So that's it for me. I will appreciate very much your attention. Thank you.
Judy, that's phenomenal work, and of course highly needed, and that shows you when you really analyze a problem to the depth that you and your group have done, what you come up with. So with the RED AVM score, looking now retrospectively to previous publications, what have you seen can be discounted as not really significant in predicting rupture of the former papers that have been published in the last 20, 30 years? What factors you think are really not relevant and were talked about before?
Right. Yeah, I think that, there's so much, I think, because so much is based on retrospective information that it is, I hesitate to say that anything can be discounted entirely, right? But it is true that some angiographic features we were not able to demonstrate as predictive, but that is true for our cohort, which is over 700 people, but that's still a small number compared to everybody else is experienced. So we don't get things like venous outflow stenosis as being important. We didn't get location in terms of like specific basal ganglia versus like brainstem. We just have deep as a sort of general category, but we couldn't get much more granular than that. So
yeah, but I think the ED one makes perfect sense, huh? Exclusive deep. As opposed to multiple venous outflow.
Yeah.
Certainly.
Yeah.
Any of the panelists want to ask a question, or otherwise we'll leave it to the discussion at the end. Ali, you want to say something?
Sure, Judy, wonderful talk. What roles do you see for embolization? And in what cases do you use it in your practice?
I do. So for me, I find it most helpful for preparation for surgery. And I tell patients that. I find it's incredibly helpful to sort of mark the feeders if that happens, right? And decrease the turgor in the AVM, and so I think it makes it becomes an easier mass to remove if there's some embolization material in AVMs that come to resection. So that's really where I use it. I used to do it before radiosurgery, and I've gotten away from it actually because of these other authors' publications.
Judy, I have a quick question. Thank you for this great lecture. I had the pleasure to actually see you speak before COVID at Jefferson on the topic. My question to you is, for angiographically cured AVMs, either via embolization or stereotactic radiosurgery, do you still recommend resection for cure?
Yeah. So I don't unless they hemorrhage, and I have actually encountered that. So I have patients that have had angiographic cure, whether that's with embolization or with radiosurgery, and years later they present with hemorrhage. And I have a very remarkable patient, incredibly remarkable in that she had every GI surgery possible, cholecystectomy, I think, what else? I think like, esophagectomy. I think she had so many GI procedures because she kept on presenting with nausea and vomiting over, I want to say over 2 years. And it was basically, I think, because of temporary increases in ICP, because she would have these small hemorrhages at the site of her obliterated AVM, technically obliterated because it was not filling on angio. But she eventually developed hydrocephalus. So she was actually communicating hydrocephalus, and I did take out her AVM, and it was this rigid, calcified, hard mass. So just incredible. You sort of have to be aware of that possibility years down the road.
Great. Thank you. Oh, Ali, you have something else? No.
Dr. Morkos, you used to talk about angiographic negative and using other modalities if it enhances on MRI that you may think it's still active.
I mean, I have seen, as you know, Roberto and I have had a few cases where it's completely dead on angiogram, and that we've had to operate on, and they were live, not very high flow, but certainly live at surgery. We saw that enhancement helps predicted, but we don't have tons of those patients. Yeah, it's interesting. Staff, did you ask the question because you had a contrary point of view about it, or?
No, actually, similar to what Judy suggests, we've had a few radiosurgery cases where sometimes upon completion of the obliteration of the AVM, you will have, right as the AVM occludes, you will have a hemorrhage, and some of the hemorrhages could be delayed. There are 3 or 4 in our series that I could recall. And I was just wondering, is there any way we could predict which one of those would hemorrhage and which one of those are worth resecting? Some of the criticisms I've heard from other colleagues is whether there are some still peel components of the AVM that continue to fill, and if the AVM has been embolized, the embolicis, precludes you visualizing that on angiography. Yeah, it'd be great to select those for resection.
Yeah, yes, indeed. Okay. Let's actually, Ignacio, can I ask you to play now Clemens Schirmer pre-recorded presentation?
Yes, sir.
On modality naive treatment of unruptured aneurysms. He's somewhere on a plane or so, I'm not sure where he was going.
Good evening, good day, wherever you are. I'm hoping that you're enjoying this symposium, and I would like to thank Jack and the organizers for the opportunity to come back to you. I'm going to talk about a topic that is near and dear to my heart. I'm going to call this modality naive outpatient treatment of unruptured aneurysms. Basically, what we're talking about, and here are my non-relevant disclosures to this, that at Geisinger, we've been really trying to push the envelope both on the endovascular side, but also on the open surgical side. And I believe that the second part of this is really the key to bringing the right therapy to the right patient without having to discuss the externalities of the treatment. How long are you going to stay in the hospital? How long is your scar? All those things that don't really matter too much when it comes to the actual treatment of that unruptured aneurysm, but matter very much for that patient. And I'll get into this a little bit more. For those of you who don't know what Geisinger is, we're a very large integrated healthcare system in the middle of Pennsylvania, and we have a robust number of cases here. But also across the country, that the treatment of unruptured aneurysms has been decreasing on the open surgical side. We've been clipping less and less aneurysms. And this is just a graph here on the right side that conveniently enough stops in 2006. I would venture to guess that if we continue this graph, that we're looking at a very low percentage of patients that still undergo clipping of an aneurysm, although we do believe as surgeons that oftentimes the treatment option of clipping is actually a better option for that patient. We do think that the treatment of an unruptured aneurysm really should minimize the actual morbidity and mortality, because we're taking a patient that is otherwise mostly completely normal and has no symptoms from that aneurysm. And we currently overemphasize perhaps the treatment modality, and that the patient preference, if you allow for that, is oftentimes based on drivers of outcome that don't overlap with the technical success. Again, patients worry about how long they're going to be out of work, how long are they going to stay in the hospital, how long is their scar, how much is going to be the pain after that procedure. And here we sought to demonstrate that if you combine the right elements of innovation on the open surgical side in the cerebrovascular arena, that you can employ a modality-naive approach to this and achieve highly reliable and successful outcomes. And this in particular is also relevant in this time of COVID-19, where we continue to have and see more often right now resource constraints, where we don't have any beds, we don't have any outpatient beds, or the ability to bring patients in for elective procedures. Looking at all these components of care that allow us to still provide care to the patient, bring that care to the patient in a reliable and successful manner is really worthwhile, and taking apart this care pathway. Setting the stage, craniotomies are not that easy. We believe that they are, but if you dive into this a little bit, we looked at roughly 180,000 patients or so over the last 7 years. And you can see that the mortality rate is not, that low. It's above 5%. Even though you can look at different age strata here, it is significant to talk about. It has a significant complication rate, and readmission also are a vexing problems. And of course, the length of stay across the country for craniotomy in general, and this is not for just aneurysms, is somewhere around 5 to 6 days. Patients also really care about that outcome a couple of years later when they come back to you. And my experience has been that they care more about their scar or that dimple where the scalp has retracted into the craniotomy hole, the burr hole, about that than whether or not you saved their life from a very technically challenging aneurysm. We see a lot of times patients with this kind of a craniotomy, but we really want to get to these minimally invasive approaches, which have a lot of advantages. If you combine that as an approach type with the right early recovery model, and we've done this here at Geisinger, that we put together a bundle that is relevant to all craniotomies, but in particular also allows for a fast track where we send the patient home the same day under certain selected circumstances. And that includes the avoidance of opioids, intraoperative scalp blocks, looking at less indwelling catheters for short procedures, using, for example, not a groin stick, but a radial A-line for intraoperative angiograms if necessary. And we've had a lot of success for that. And this really sets the stage that we can compare our outcomes before and after, but really have a good way of minimizing the perioperative morbidity, mortality, complication rates, and other metrics on the open side, and really focus therefore on what is mattering to the patient. They want to go home as early as possible, and we're able to show that our discharge disposition has increased for open surgical procedures. They go home more often, and that is not bought or encountering a higher rate of readmissions. So we're not paying the price for sending the patients home too early, perhaps. Now we're going to look at, can we really measure a difference if we look at that different modality between endovascular treatment and open vascular treatment? So here we are going to consider a 5-year analysis, prospectively collected and independently adjudicated patients. The total number is 585, but we excluded a couple of surgeons who did less than 2 procedures in total. So we're left with 578 patients. You can see here the distribution of the different practitioners. There's one surgeon who did about 1/3 of the procedures, and then we have 3 more that did roughly another half combined. The basic demographics are here. The median age is about 58 years old. 90% of these were less than 80 years old. 72% were female, and reflecting the geography here that we are in the middle of Pennsylvania, 92% of our patients are Caucasian. And we're looking at middle of 2015 to the middle of 2020. And 94% of these had an elective admission status. Both facilities that were considered in this analysis are a comprehensive stroke center from a Joint Commission perspective. And you can see here that the different centers, I'm sorry, all 3 centers are Joint Commission centers. We clipped about 23% of these patients, and we treated 77% of these patients from an endovascular perspective. About 3% of these patients were enrolled in what we call a fast track program, meaning that they were considered for going home the same day. That is not the standard, but we offer this to patients, and we also select our patients for that option if we think that you're a good candidate for that. Most patients that are appreciate that option very much. As you can also see here, we instituted what we call the Proven Recovery Craniotomy Module, which is an early recovery module around craniotomies. In about 12% of these patients, 88% of these patients were still treated under the standard of care. And that includes the 88% includes the endovascular patients. Looking a little bit more into the demographics of this, you can see here that the age ranges are not significantly different between endovascular therapy and open clipping therapy. The treatment overview is as such that we observed a certain baseline of complications, mortalities, and others. And you can see here that our baseline mortality rates, complications rates are around what I mentioned before, 8 to 9%. Readmission rates are actually quite good over 30 days. They are between 4 and 5%. A lot of our patients are being discharged to home or self-care, but there's a significant number that needed to have rehab or other support afterwards. And again, these are patients that are coming from home, so they're not arriving from a rehab or nursing facility for the most part. It is also important to keep in mind that the early recovery modules started with a single surgeon, yours truly, but we expanded that to multiple surgeons, and we can show and look into the differences between that single surgeon cohort and the multi-surgeon cohort, because again, a lot of practices that we do are easily done when you're looking at just one surgeon. The trick sometimes is to expand them and come back and make that a new standard of care that everyone subscribes to and is actually reliably able to participate in. You can see here the breakdown over time. The majority of these are done in the comparison group because we go further back, but we can look at the entire proven recovery group and see that there's not a lot of a difference here. Looking at just the general trend of the event rates, we can show here that, of course, the majority of these procedures done really, really well. They did not have any mortalities or complications. That's where you see those big fat dots here at the 0 mark for a lot of these. The length of stay is, relatively short for a lot of these, but you can see a difference here between open clipping and also the cost per case. That's important. Endovascular procedures are more expensive. That has to do with the direct cost of some of the devices that we use. But you really have to weigh that against the whole picture sometimes. And that's an important nuance to keep in mind. There's an evolution over time here. You can see that there's very little change in the endovascular group of patients on the left side here. When we're looking at for example, the length of stay, We have seen a little bit of a trend to being discharged on the same day. But overall, that's been pretty stable. The length of stay was not very different before and after for the whole group. But there's a significant difference in the group that were treated with open clipping and where ERAS, or the early recovery module, was adopted. And you can see that here on the right side in 2018, 19, and 20, you see a significant decrease in those length of stay data points that allow us to drive an inference here as to that we're essentially converging to the standard that the endovascular group is already setting. The single surgeon experience does matter. You can see here the difference in blue compared to the red denoting the single surgeon experience here. But overall, we see the same trend lines, and that's important. It's just going to take a couple more time periods to adopt and converge to that single surgeon experience. And you can see that here on the right, that the adoption and the convergence is a little bit slower. The slope of that blue curve is less driven down. But again, this is the endovascular experience here in blue, whereas you see that for the whole group, the length of stay on the open surgical side is converging down and will perhaps actually go less than the endovascular average. But that's probably just a artifact here of the first order linear approximation of this curve, and it will probably converge to being about the same number. Looking at what we call O2E ratio, so we have a risk-adjusted, outside adjudicated observation. We use Premier for this. There's other databases that you can use for this. Most of you are either a member of Premier, University Health Consortium, or others that allow you to have an outside measure or benchmark of quality and looking at your risk-adjusted cases and how that compares to your comparison institutions. Looking at these O2E ratios, we note that a ratio of 1 means that your expectation and your observation line up, meaning that you're as good or as bad as your comparison institutions that you picked. If your observation is less than 1, your O2E ratio is less than 1, you're a little bit better than the outside benchmark. And if it's more than 1, you're a little bit worse than the outside benchmark. And you can see here that, some of these are quite high, but the range is quite high. So we do have some outliers. But for the most part, the median values, and that's what you're looking here for, is around 1. And that's really, really good. But you can also see that there's a little bit of a left shift in the recovery and cost, length of stay, complication rates in the group that was done during the time that we instituted the early recovery module for open surgical procedures. Mortality remains really, really good. We did have a few outliers. Because of our low numbers, having 1 or 2 events is significantly different. So in the time period that we had open recovery, we did have 2 events that were mortalities, and that is significantly worse than in the group before. But overall, these are rare events, and we will have to dive into this a little bit of how to properly couch this in a statistical manner, because I believe actually strongly that that's not a correct way of looking at this. But at any rate, we were significantly worse for mortality in the period of time that we were using early recovery and the fast track program for craniotomies and clipping of unruptured aneurysms, although none of the patients that died were subject or part of the fast track program. Complication rates are overall not changed. That is about the same. There's a little bit of a trend to less rates, but that is not significantly different. And diving into length of stay, there was no longer a difference, which is really what we're looking for here. And the endovascular length of stay was 0.74 days. The open length of stay is 0.73 days. And you can see here the differences are really not existent anymore. And that is significantly better than the baseline. Of course, if you do have a complication, that will adjust the length of stay and express itself in a longer length of stay. However, that is the same between a single surgeon experience and also a group experience. And it doesn't really matter if you have a complication or a readmission, and that is being sort of like, pushed together, and we see the same trends here. What is really important is the discharge disposition. We made significant headway here. So we started in this quadrant where we're seeing that a lot of patients were not discharged to home anymore, even though they came from home. You can see here that a lot of patients went to rehab or even nursing facilities. Whereas we now are in a position to say that most of the patients, if not 100% on the open clipping side, actually went home. And that's a significant difference and positive change. Again, all-cause readmissions. So again, we were seeing before a significant difference here that was much higher on the open surgical side. But there is no difference anymore. And again, that's what we're trying to achieve here. And then also cost is obviously related to the treatment modality. Endovascular procedures, again, are more expensive, but it is no longer related to the operator. And mind you, I didn't say this before, that all the operators in this cohort are dual trained surgeons, with one notable exception of one of our partners who only does the endovascular procedures. Looking at the O/E ratios here, we are able to show that we have a convergence towards 1, which is really important. And before that, we were seeing that the endovascular procedures were way out of line, and the open procedures were a little bit above 1. Now our open surgical procedures are actually significantly less than 1, which is not good for the comparison of endovascular procedures, but it is a very significant development on the open side, because it basically allowed us to bend that cost curve down, which is something that is difficult to achieve these days when you have the cost of medical inflation, which generally drives these procedures up and includes the O/E ratios. So in conclusion, I want to point out to you that we are at this point in the enviable position that we have very little differences between the open surgical procedures for the treatment of unruptured aneurysms and endovascular procedures. We have a mortality rates less than 2%, and we have readmission and complication rates that are very, very low compared to national standards. Our length of stay is, as you can see here, roughly 1.3 to 1.4 days, and the open surgical length of stay is actually less than the endovascular length of stay. And that's been a journey that's been really beneficial, because it basically allows us to leverage the innovation on the open surgical side correctly and come back to the patient with the right recommendation that is based on what is the best technical treatment for that aneurysm, rather than to focus on those externalities that both the surgeon perhaps, but more so the patient, is really focused on, and allows the patient to participate in this decision-making process without having to worry about those externalities. And that's what we call a modality naive treatment approach to this, because you achieve that technical outcome without having to look at those externalities. And the second takeaway from this perhaps is that 96% of these can be done as an outpatient, which is really important in this time of resource constraints and the inability to bring patients as an inpatient into our hospitals. And it allows us to continue to drive the ability to provide care for these patients without having to worry about that this is a undue risk for the patient, and doesn't allow us to focus on the sicker patients in the hospital, but stop doing care for those patients who need this and are really anxious waiting to have their unruptured aneurysm treated. With that, I hope that this was helpful and happy to take any questions. You probably all know how to reach out to me. I do want to thank my whole group for participating in this. This has been quite a journey over the last 5 years, but we really felt that this is a really good approach to bring care to our patients, and it's been wildly successful so far. Thank you very much.
Well, I thought that was great. I don't know if any of if you want to say comment. I know he's not here to answer, but any remarks, any comments before I invite staff to speak? Okay. Staff, bring it home.
Okay. Saving the Greek for last.
Saving the wonderful name of Stavropoulos. I don't know why we should quit calling you Stav. Stavropoulos is so much more, musical.
I'm going to respectfully correct the accent. It's Stavropoulos, but you're really close.
Okay. Well, had you told me, I would have said it right. Okay.
Okay. So again, really a big thank you to Jacques for the invitation, and a big shout out to Bobby Stark, who was here at Jefferson and has really co-authored most of our papers, has done a great job in doing statistical work for us. These are my disclosures, and main disclosure is really, I'm very fortunate to be at Jefferson with this phenomenal group led by Robert Rosenwasser and my partner in crime, Pascal. So we're going to move through quickly, like the endovascular cases go, Jacques, and we're going to, of course, talk about endovascular, which really started by Egas Muniz with the introduction of angiography. Obviously, Cerebrovascular had already taken a head start with Harvey Cushing, was the first to describe wrapping of aneurysms and packing them with muscle to elicit thrombosis, perhaps an early attempt for endovascular, but it wasn't until Dr. Walter Dandy performed the first aneurysm clip. So we have progressed since then from the OR to the INR, and this is the interventional suite, the new way of treating aneurysms. And by the end of the day, I'm going to show you that we're going to progress from the INR to home. This is the evolution of endovascular neurosurgery in terms of devices. And flow diversion came a little over a decade ago, and it was a major disruptive innovation in current endovascular devices that you see here, with the major change in aneurysm treatment. There's a great paper in AJNR that was published 2 years ago that really shows the endothelialization process that occurs and facilitates the membrane formation following linear flow diversion as shown here. These are the current FDA approved flow diverters, the pipeline device, which is nearly 10 years in approval and usage. And then other linear flow diverters, so the Surpass and Fred devices. And then we now have a new generation of flow diversion, the endovascular kind, with the web and upcoming contour devices. So these are the major trials that I've left to the safety and efficacy of flow diversion, and the progressive aneurysm occlusion, which you see here, and most importantly, safety, very safe procedures with very low morbidity and mortality. This led to the FDA approval of the pipeline device as the first device. And on-label approval earlier on was restricted to aneurysms from the petrous to the hypophyseal segment, which obviously was a little restrictive early on. And then there were several studies and registries that helped us with some of the findings. For example, the Interpret registry showed that the posterior circulation had higher risk when usage of flow diversion for treatment of aneurysms. So we really take that into account when we use flow diverting devices. These are some of our papers and some of our experiences. These are our first 40 aneurysms, significant learning curve. You'll see that our complication in our first 40 was as high as 14%, major and minor complications. And if you split them into groups, we'll see the first 20 devices, significant morbidity, and then the second and third groups, really nearly 0% major complications. So the treatment of paraclinical artery aneurysms has really been revolutionized since then. You can see here several paraclinical aneurysms. treated with a single device with excellent results. Some of these aneurysms are very complex. This is a trilobe ophthalmic artery aneurysm with a single device, a complete aneurysm occlusion and obliteration. Recently, the premier study, which was a prospective multi-center study, confirmed the efficacy of the device, nearly 80% complete aneurysm occlusion in 1 year. And again, the safety of the device, 2% major morbidity and neurological death at a year. Unlike previous studies, in this study, we've proven that only one device is required as opposed to the prior studies, and that really decreases the overall morbidity of the procedure. Some myths that I want to discuss in terms of flow diversion, that you shouldn't cross certain arteries, for example, the ophthalmic artery, that it will occlude. This has been well published in the greatest majority, 90% of the cases, the ophthalmic artery stays patent. In the remainder, we may have a asymptomatic occlusion, and very rarely, less than 5%, you can have a symptomatic occlusion. When treating large aneurysms, unruptured, we've published our series, and we found that using a flow diversion versus coil is actually more efficacious, and we have a significantly higher aneurysm completely occlude with flow diversion, nearly 90%, as opposed to the traditional coiling embolization. So perhaps more studies need to be done for these large aneurysms to compare with open surgery. In terms of follow-up angiography, we published that once the aneurysm is 100% occluded, there has been 0 reports of recurrence of the aneurysm. Now we have long-term follow-up up to 10 years. Therefore, even at 6 months, you can tell comfortably the patient that they have been cured, similar to you telling your clipped patient that their aneurysm has been cured. What about the in-stent stenosis? Some of the predictors that we found, almost all of them were asymptomatic, and the main predictor is the lack of aspirin therapy. So if you're going to use flow diversion, long-term aspirin therapy, aspirin 81 milligrams daily suffices. We will be protective against in-stent stenosis. Another predictor that I found from one of my own patients was actually sickle cell. And in sickle cell patients, when they have a sickle crisis, as you know, they can form clumps of the abnormal red cells, and that can actually occlude and stenose the stent. And you see here, the treatment for those can be as simple as an exchange transfusion. This is pre and post exchange transfusion. You can see that the stenosis has significantly improved. What about the PCOM artery and the posterior paraclinoid aneurysms? But we found in our series that the aneurysms that are fetal PCOM have 100% patency in follow-up following flow diversion. And here's an example, pre and post flow diversion. You see not only the aneurysm continues to fill at 6 months, now you have a bigger problem because you have to still treat the patient with microsurgical clipping. You have to stop the aspirin and increase the risk of perioperative stroke. So in our series, every fetal PCOM aneurysm will either get clipped or treated by another way and not by linear flow diversion. A single device is sufficient for treatment of all these aneurysms. We also have the PUFS original trial, now has a 5-year follow-up that was published 2 years ago. And what they found was what happens with the remainder 15%. We said overall occlusion of about 87%. What happens to the remainder of those patients? Do they need to be retreated? And the answer is no. If you just sit tight and wait, the aneurysm occlusion doesn't stop, and the occlusion is progressively increased over time. They looked at 1, 3, and 5 years in this multi-center trial and found that it increased progressively to nearly 96%. So long-term in this study, also very safe, 96.5% of patients had excellent modified ranking scores. So this all led to the expansion of the original FDA approval indications to include aneurysms all the way to the carotid terminus. There's been 2nd and 3rd generation devices now for the pipeline device. We're now in a 3rd generation device. And similar to the FDA, here locally, we're expanding our indications. This is a patient that came to me for a second opinion, has dysplastic pica mid-segment aneurysm with the Murphy's excrescence, partially fusiform. with some inflow stenosis. And with a single stent shown here, on the pica only, we have a nice aneurysm occlusion at 1 month follow-up. This is another patient with a large partially thrombosed right MCA aneurysm. We've all treated these open, and they can be quite challenging cases. And this is with a single stent. You can see complete aneurysm occlusion and 6 month follow-up. Some more complex cases, we have now treating inflow aneurysms to this posterior occipital AVM. You can see the irregular aneurysms at the basilar apex and proximal P1. As we know, these have a higher propensity to rupture. With a single stent device, you can see a 6 month follow-up, complete aneurysm occlusion, and nice protection of these inflow lesions. And then we went on to treat the AVM. Other areas where we've pushed the envelope is treating fenestrated aneurysms. These are very challenging cases, and we've published our series, although limited. We've treated close to 10 patients now. Most of them tend to be in the basilar trunk. And the treatment here is to flow divert the dominant limb of the fenestration and coil deconstruct the non-dominant limb. And you can see here excellent long-term follow-up. Some other cases can be more complex. This is a patient that was transferred with a breakage in the construct, and we can actually navigate carefully through the devices and bridge the breakage and salvage the stent. You can, if you have to, do bilateral flow diversion. We don't recommend you do them up front. This is a young nurse who had bilateral large ophthalmic artery aneurysms and was treated on one side successfully, waited a few months, make sure that the treated side doesn't have severe stenosis at the stent, and then went on to treat the contralateral side, as you see on the right, with excellent 6 month follow-up. What's new in linear flow diversion? We have new devices. This is a pipeline shield device that have actually external coating that decrease the risk of thromboembolic events because it mimics the outer membrane of the red blood cells. Several trials are investigating whether we need to use dual antiplatelet therapy for these flow diverters or not. This is the surplus device, very similar to the pipeline device. A new device that seems to be exciting is the FRED device by Microvention, gained FDA approval 2 years ago. And this stent is a little bit different because the proximal and distal tines of the stent have non-flow diverting segments. And this can be very important when you treat aneurysms that are close to a bifurcation, as you see here, this PCUM artery aneurysm that recurred following subarachnoid hemorrhage. We were able to treat it and land the non-flow diverting segment at the carotid terminus, therefore not jailing the A1 and potentially causing ischemic side effects from that. Here's again another example of the non-flow diverting segment ending in the carotid terminus. This is a deployment example of the same aneurysm, very easy to deploy, almost like a self-expandable stent. And naturally, we went on to do many cases with this new device. And you can see here, this in the middle is immediate stasis following a single stent in the ophthalmic segment. We call that the eclipse sign, which is a great prognostic indicator of complete aneurysm occlusion on follow-up. These are some other cases, a posterior paraclinoid ophthalmic aneurysm and a superior hypophyseal artery aneurysm. A lot of times these devices are resheathable up to 3 times. If you don't like the original deployment, you can resheath and redeploy. And these are some more challenging aneurysms. This is a patient 60 years old with a history of left craniotomy for clipping of an MCA aneurysm, came with increasing headaches and right-sided paresthesias. And you can see here on the MRI, he has a large recurrence of his MCA, partially thrombosed. You can see part of it is filling, but the greatest majority of it is actually not. This is the MRA. And you can see here to the right on the 3D reconstruction, the steel from this giant aneurysm. It doesn't capture the entire filling of the aneurysm. Here's the part that's filling on the left side on the source data. And this is the angiogram. One of the real challenges of this case is not just the fusiform segment, but you can see the aneurysm fills in different phases of the angiography. You can see the inflow in the early arterial phase and the outflow in the late venous phase. And this leads to a dominant M3 on the dominant hemisphere, certainly not an artery that you would want to deconstruct and sacrifice. This is, again, the same case. And this is high magnification to add more to the challenge. You can see inflow severe stenosis leading into the aneurysm. Obviously, this is a high-risk case with open vascular because of the previous craniotomy, the giant size, and all those angiographic factors I showed you. So we chose to build a flow diverting construct. And oftentimes exiting a giant aneurysm is probably the most challenging part of your case, as you see here. And this is building a flow diversion construct. Here I use the Fred device. And you have to be very cautious not to exert a lot of tension into the system, because you can herniate the whole construct into the giant aneurysm with catastrophic consequences. This is landing perfectly right at the area of the stenosis. The reason I chose the Fred, you can see here on the right, I was able to land the non-flow diverting segment into that stenotic area to decrease the likelihood of the aneurysm and the N2 occluding. And this is the angiogram following deployment. This is the construct of the 6 stents. This is a short-term follow-up angiogram. The patient's neurologically intact and doing very well. What's new in linear flow diversion? We have smaller devices. This is a Fred Jr. that allows you to navigate very distally. This is treatment of a previously ruptured and recurred pericallosal artery aneurysm. And there's a new generation Fred device coming up as well in a month. However, we have now changed flow diversion, and we now have endosaccular flow diversion, where we deploy a single device within the aneurysm sac. And this is indicated for carotid terminus artery aneurysms and bifurcation aneurysms in general. This is the papers that led to the safety and efficacy and FDA approval of the device. These are some of our cases that we published in these papers. You can see here really nicely an ACOM artery aneurysm with great follow-up. Similarly, MCA, complete aneurysm occlusion at 6 months, and the only remnant of the aneurysm are the proximal and distal tines of the web. This is another MCA artery aneurysm, and this is a basilar apex. So FDA approval for these endosaccular device is almost 2 years now. Like any device, sizing is very important and it's key for correct deployment. In the middle, you have the correct deployment. If you compress the device and exert too much tension, you're going to leave a remnant at the neck, and also you have a higher risk of rupturing the aneurysm. If you have too much tension here, you'll see that you run a higher risk of occluding the bifurcation and causing later ischemic events. We've published our initial 64 aneurysm experience with great results. And we also published our treatment of subarachnoid hemorrhages with the web. It actually tends to be my device of choice for wide neck aneurysms and is a nice complement to microsurgical clipping when appropriate. What's the advantage in subarachnoid hemorrhage? You don't need to use dual antiplatelet therapy, just aspirin. And sometimes you don't even have to use aspirin. This is an example of a basilar apex artery ruptured aneurysm. And this is not at 6 months follow-up. This is immediately following aneurysm treatment on the table. You have complete aneurysm occlusion with a single device. This is another complex aneurysm. This is an ACOM aneurysm, multi-lobed. And you can see here immediate aneurysm occlusion with a single device. When the aneurysm is irregular, such as the previous ACOM, you see here a Murphy's excrescence proximally. You don't have to fit the whole device in the aneurysm, because oftentimes you can occlude an excrescence by secondary intent, as it's really nicely depicted here. As always, new technology has new caution. You see here sometimes when the device comes up, the whole microcatheter can lead into the dome and cause a rupture. So you have to As always, use very caution, especially in your first few aneurysms. We push the envelope. These are some complex aneurysms. This is a bilobed ACOM with superior and inferior projections that was treated with 2 distinct webs. And this is post deployment of the web. Again, this is now the web stasis, which is the new eclipse sign. And as always, Jefferson, we're pushing the envelope and the limits. We're treating sidewall aneurysms. This is a fetal PCOM. Obviously, more caution needs to be used here because you have an additional angle when you're deploying the device, and you just have to be very comfortable with bifurcation aneurysms before doing something like this. This is deployment of the web device. This is detachment of the device. And this is, you can see here, nice stasis within the aneurysm web. Again, very great progressive indicator. This is an ophthalmic artery aneurysm that I didn't want to use flow diversion in the setting of subarachnoid hemorrhage. And with the single web device that you see here, you can see near complete immediate aneurysm occlusion. This is actually just from yesterday's cases. This is an irregular basilar apex artery aneurysm. Again, similarly, secondary intent of closure of the Murphy's excrescence with a single device. And you can see nice stasis within the aneurysm immediate following deployment. And this next case is a M1 artery aneurysm. You can see a lenticular striate coming off of the aneurysm, obviously. This could very well be treated with microsurgical clipping. The patient opted for endovascular treatment. And you can see here, once we deploy the device, we're actually able to contour the device within the sac. And you can see here, by exerting a little tension inferiorly at the pole, I was able to allow filling and distort the device at the takeoff of the lenticular striate to be able to preserve flow in that artery. Web 17 is new and exciting. It's a much smaller device, 17 meaning the microcatheter requiring to navigate into the vessels, which is the smallest one we have. And this is a patient that was treated at a very distal M2, M3 junction aneurysm. And this was treated with a single device with excellent aneurysm occlusion. And you can see here the secondary Murphy's excrescence obliteration. Jacques, we do love to operate, and we do have some great cases for recurrences and some great videos. This is a recurrent PCOM artery aneurysm that was treated with the web. And although these devices can adhere to adjacent cortex and tissue, they're actually very easily compressible, and the clip will actually collapse the device, as you see here. What's new in the horizon? Contour is a device that's coming to us by Cirrus from Europe. Like any of these devices, it has already been CE marked approved in Europe. This is the study that shows efficacy and safety of the device. And it's a web minus the dome. So technically, we may have an advantage in decreasing risk of rupture, not having that second half of the dome of the device. And also being able to treat more shallow aneurysms. We have our first contour case coming up on Monday. I promise you, I'll show you that from the INR, we can now go and treat the patient from home. Robotics and surgery, general surgery has been used since the 1990s, and finally it's coming into the endovascular world. Corpath Corindus has the robot that's been CE marked approved in January of 2018. And FDA approved a few months thereafter, only for peripheral cases, which means we have studied it here for carotid stenting, and it's pending FDA approval for intracranial. This is completely new and different. You have a 2-physician team. Ultimately, the physician who runs the robot, that's me here, that's my fellow at the bedside, could potentially be home with remote robotics. And this is literally using joysticks and navigating devices with minimizing radiation exposure, not adding additional radiation exposure to the patient. So these are the great advantages of the robot. They have already performed remote robotics for treatment of acute coronary syndrome in India, where the operator was 20 miles away, treating with balloon angioplasty and stent. And in Canada, that are now limited by the FDA, Vitor Pareto and his colleagues are actually using it for endovascular treatment, stent-assisted coiling, and I'm sure soon to come flow diversion. So hopefully once we have FDA approval, we'll be potentially performing these procedures remotely in areas that have great need and not having to drive into work. So I think my time is up. I want to thank you again for the opportunity, and I'll stick around for questions.
Thank you, Stav. What a tour de force. And again, I thank you and Pascal and your group for, of course, pushing the envelope. And thank God that there are people actually like you who are willing to push it, to take the risks and produce a phenomenal volume of scholarship that your center has produced. Any comments from the panelists on the vast material that Stav has covered? Ali, do you like everything Stav has said?
I like Stav very much. I'm a big
I
fan
was
of
asking you if you like Stav, just the material.
The point is that I have, I think it's very, very important to push the edge of a certain field, but it's also very important to remain balanced, and without the Stavs of the world and so forth, fields wouldn't move forward. But these concepts of same-day home surgery and MCA aneurysms with flow diverters, yes, we can show one or two, but I think the balance and yet another tool being open surgery is very important to talk about. Some of those cases I know you would treat differently. I know I would treat differently. So I think as neurosurgeons who do endovascular, I think a balanced approach in certain things is important.
Yeah, absolutely. Which is why I showed the open case. One of the misconceptions is if you're a dual trained neurosurgeon, you're not an open cerebrovascular neurosurgeon. And similar to what you said, we love open surgery. We love to clip aneurysms. We're way over 100 and 120 cases of clippings every year. But like you said, it's nice to have all the tools and all the skill sets and conform and treat, the patient based on what's best suited for their anatomy, their age, their rupture presentation, etc.
Yeah, I'll tell you a story. I was sitting in the audience with the Turkish guy, Sekirci, right?
Oh, yeah.
And a number of our friends were sitting there also. And there was a 16-year-old girl with a very large MCA aneurysm that had a flow diverter placed and came back with a hemorrhage, which we've all seen. And the conversation was with our own neurosurgeons, and the conversation was about, oh, what kind of antiplatelet regimen did you have? What did you think about the vessel? There was no conversation about, hey, what about a clip and a bypass and so forth. So I'm afraid that through innovation that the pendulum can swing a little too far. So that's sort of my thought.
Yeah, age, like you called it exactly, a 16-year-old with a large aneurysm, MCA, definitely open surgery is should be your number one in the decision-making tree. But Europe in general, I know their open surgery is unfortunately becoming a dying art. There's the endovascular world is very powerful and oftentimes led by very prominent interventional radiologist. So that's really portraying exactly the risk you mentioned, and the lack of balance, unfortunately.
Great. Why don't I invite, indeed, Eva Wu Judy is the first author of that paper, and she is a rising star. She's our PG3. She sleeps and dreams vascular and skull base and microsurgery. And she is gonna share a case and get everybody's opinion. Eva, all yours.
You see my screen, Dr. Morcos?
Yes, I do.
Okay. Yeah, thank you for the shout out, Dr. Huang. It was really nice of you. And then thank you, Dr. Morcos, for giving me this opportunity to present. I apologize for my voice. I'm a little hoarse. I conveniently, lost my voice right before the Symposium, but yeah, and thank you for all the panelists for all their
We hear you well.
And so, we chose this case actually because we thought it was interesting. There's several different approaches for this patient. And so we wanted to get the opinion of the expert panelists. So this is a 43-year-old female who actually presented with a syncopal episode and the worst headache of her life. No focal neurological deficits and no relevant past medical history. On CT scan, it showed this diffuse subarachnoid hemorrhage, eccentric to the right sylvian fissure, and then this possible MCA bifurcation aneurysm on the CTA. And so here is the angiogram that was done. And so we wanted to turn it over to our expert panelists now and ask them, number one is how they would describe this aneurysm, and number two, how they would manage this patient.
Stav, how is this patient managed today at Jefferson? And you can see I'm sure you can see the top right.
Yeah, sure. So what was the Hunt-Hess grade on this
It
patient?
was Hunt-Hess 2.
Yeah, and the age, sorry?
43.
Yeah, so bifurcation aneurysm in the MCA, irregular with at least 2 Murphy's excrescents. You can see in one of the views, you actually have a very small M3 emanating from one of the aneurysms on the lateral neck of the aneurysm, and a very shallow neck. The dome to neck ratio is unfavorable. This Jefferson only really has one way of being treated, and that's microsurgery for clipping. This is not an aneurysm. Even in an older patient that would consider doing coiling embolization, you see has a wide neck. You could consider securing the dome, but you just don't have enough dome to neck ratio. Similarly, none of these devices that I mentioned earlier would work. We do not do linear flow diversion in bifurcation aneurysms, so this would never be pipelined or anything like that. So I would clip it.
Judy?
You may need more than one clip, actually.
I'm very happy to hear that because that's exactly what I would have said.
Okay. Ali?
Same, Dr. Morcos. There's always been talk about stenting and soul stenting and changing the angle of vessels and whether that obliterates things, and there are people that would put flow diverters in this, but I don't think that's the correct thing to do.
Okay. Eva, what was done on this case?
Yeah, so another neurosurgeon actually ended up clipping this aneurysm. So they actually ended up doing, on this left side, you can see there's a straight clip that's going across the inferiorly pointing aneurysm, and then they did a fenestrated clip across the frontal M2 to clip that superiorly pointing aspect. And so a post-op angiogram was done, and there was no residual aneurysm. The patient did well post-operatively. However, 4 weeks later, she actually had a possible fall and hit her head and had headaches and nausea, vomiting, came to the emergency room. And so on CT scan, this is what it showed, this hematoma in the surgical cavity and next to the clips. And so we did another angiogram, and then this is a right lateral ECA injection. The middle is a lateral right ICA injection, and then AP right ICA injection. You can see this recurrent growth of this MCA bifurcation aneurysm. And so here's the 3D reconstruction. And so we wanted to ask the panelists, again, number one, how would you describe this aneurysm? And number two, how would you manage this patient?
So Ali, why don't you take it up first? How do you interpret this case?
I'm sorry, so was there a post-op angiogram that showed complete obliteration?
Yes, go back to it, Eva. Show them the post-op angio immediately. You could not find any residual on this good quality post-op angio. You can see that the surgeon put the fenestrated clip across the M2, and that I think the clip blades touch each other, you know, the two clips. And then if Eva goes to the new angiogram, you will see a separation between the two clips. And on that 3D, that bottom, yeah, you see like a toothpaste squeezing of like I guess a pseudo aneurysm. That's how, would you agree with that interpretation, or what would you say?
Yes, Dr. Morcos. I mean, was it a dissecting aneurysm? Did this trauma have anything to do with?
The trauma was minor, very minor. Yeah. I don't know if she fell because of the second hemorrhage. It was a minor fall at home. We were not impressed by the history.
Right. And there was nothing intraoperatively in terms of coagulating the neck or an intraoperative rupture that had to be wrapped or anything like that. It was a straightforward clipping.
No, by speaking to the surgeon, the description of the second clip with the fenestration was that it was on that thin, the one that Stav mentioned, that second tip, the very thin wall. There was barely enough tissue to grab, but he grabbed it, and that was the result.
Yeah, so whether this is a dissecting a dysplastic vessel that was circumferential, that's probably what caused the regrowth. The question is what to do now. It looks like it's off of one M2 branch. The options are to go back in and reapply clips and remove and so forth, or to bypass to that M2, or even on the surface, figure out which distribution this M2 goes through, an STA, MCA bypass, and then close this off, sacrifice the vessel. I think that's the right way to go.
Judy.
Yeah, I think that's a very good option. I think I would first ask if there, the opening, the inflow into this recurrence looks like it's very small, and would just confirm that for anybody who does endovascular, that would not be a good accessible way to deploy additional coils. I would assume not, because it's not a big recurrence, and I would think that it's difficult to access. Do people agree with that? That it's an endovascular coil at this point is not great.
Do you have 2D?
Do you have high mag? The 3D is a little hard to see what's anti-massage and what's.
I wish we included the actual 3D rotation.
The 3D rotation. Sorry, it was just.
Oh, here we go.
Yeah.
Is that going to help you guys?
See, it's hard to
I
see
needed
the neck.
just a biplane right at the neck to see.
By the way, the clips have been subtracted. This is how it is without the clips. I mean, the general question on a scenario like this, Stav, would you consider endovascular with a very rapid regrowth? We have to assume it's at least partially pseudoaneurysmal wall. I mean, it's impossible.
So I totally agree. I actually had one of my own cases of ruptured aneurysm. It was a blister ACOM that I clipped. Similarly, intraoperative angiography was negative. The patient was still in the hospital. She did great. And 3 weeks later, re-ruptured. And very similar to this, she had almost 3 times the size of a dissecting pseudoaneurysm. So these are dissecting events and pseudoaneurysm formation, not from the head trauma, but from the trauma of the clip. At one point, and it sounds like there was an issue with one of the M2s, they probably dissected and traumatized enough to create a pseudoaneurysm. So I would really love to see the the high magnification right on the frontal and lateral projection. But in general, and the way I treated my patient, I was actually able to get through that small inflow and occlude the aneurysm, especially if the patient re-ruptures and comes with a higher grade. Very important to do a short-term follow-up if you're going to do that because of the large pseudoaneurysm size. And similarly, intraoperative angiography, even in a very busy place, one thing I learned from that case is if you're really worried about the aneurysm and it's small or has a shallow neck like that one, do a dedicated angiogram the next day. Although the biplane intraop angiogram may show what you think is aneurysm occlusion, you may not be fully occluded and pick up an early pseudoaneurysm. So, but I would try, if possible, to treat this endovascularly as opposed to opening. And I don't know what her Hunt Hess grade was, but oftentimes these re-ruptures are pretty significant with associated, increase in the Hunt Hess scale.
She was perfect. On amazing re-bleed, she was perfect. She questioned whether she needs to be in the hospital. She was so good. Yeah.
So yeah, I would still try to go endovascular. Sometimes you can actually put a small microcatheter at the inflow and do a micro run and see if you have any outflow M3s or any other arteries. If there are none, I would actually try to secure via an endovascular route.
Okay, Eva, tell them what we did. I got involved at this stage, and go ahead, Eva.
Yeah, we considered, all the options that the panelists brought up. We actually ended up deciding on reclipping the aneurysm with a possible bypass. And so here we isolate the both branches of the STA in situ, just in case we need the bypass. We reopen the cranie and then extend the craniotomy temporally to allow for more space. And so I'm just going to fast forward through some of this because we're running out of time, but we get CSF from the opticocarotid cistern to relax the brain. Then we obtain proximal control. And then here is A1 and M1. Then we obtain proximal control at M1. And then here's the M1 as well again. And then here's where the aneurysm, the fenestrated clip is right here, and then the straight clip is back in this back. And so here we evacuate the hematoma through the superior temporal gyrus, actually here. And here's the frontal and temporal M2 branches coming into view.
So if I can interject a little bit, keep playing it, Eva, it's okay. So that fenestrated clip had barely any tissue in it. And I think just kind of, and you will see in a second where the hole is. The hole is between both clips. Go ahead, Eva. Yeah.
Okay, let me fast forward a little bit. And so here we're trying to find where the bleeding is coming from. It seems to be coming from, underneath the fenestrated clip. And so we remove the fenestrated clip.
Eva, is this a regrown aneurysm? Is it a misplaced clip, or is it
this is
trauma?
actually a pseudoaneurysm sac right here.
No, Ali, all this tissue, because I watched the previous video, all this tissue is new in 4 weeks. This I'm pushing with my hand. Look where the hole is. Maybe she'll freeze it. It's an interesting teaching case. There is a temporal M2. We just put a clip on, trapped it because there was good collateral from the temporal M2. And in a second, you'll see the hole. There is the hole. You see it?
Oh, yeah.
Yeah.
Wow. Yep.
So there is the hole, and the question, okay, freeze it here, freeze it here. Can I ask you, Judy, I don't know if you have a good view of what I'm talking about. How would you handle this right now?
Yes.
So you have the hole at the bifurcation, very low between temporal and frontal M2s. Reclipping, I cannot put a clip low enough that saves the arteries.
Right.
what
It
tricks?
seems like, so the hole is at the origin of the temporal M2, right?
It's between, it's at the crutch between temporal and frontal M2, but yes, closer to the origin of the temporal M2, yes.
Yeah, that looks, and it looks like a big hole. I think you had prepared for a bypass. I think it's very reasonable to do a bypass. That I don't see a way to reconstruct that vessel.
Right. So I was ready to do the bypass, but then what was useful to me, there was excellent backflow from the temporal M2. And I said, this lady doesn't need her temporal M2. Eva, play the video. So I said, oh, and by the way, I thought of using the cotton augmentation technique, you know, of Dan Barrow and Spetzler, of putting a cotton and putting a clip, but even that wouldn't have worked. So I said, I'm going to use the stump of the M2 as a band-aid on the hole. So you see, I just cut the M2 here, flip it over, you know what I'm saying, and cover the hole, and then put the clip across both, and it worked like a charm. You know, instead of putting her through, I mean, I could have done the bypass, the STA was ready, but it's unnecessary. So, you know, I had never quite done this trick before, so, you know, but
The best bypasses are the ones that are not needed.
that are not needed, correct.
How did you assess if it was enough flow from your backflow?
Well, I had transonic flow probe, you know, I use it, as you know, quite a bit, but the vigor of the back, we edited the video, but the vigor of the backflow was very good. I just visually, to be honest with you. And then look at the ICG, it in a temporal lobe fills. The surer way would have been, of course, to do a bypass, but you know, I felt.
Jacques, if I may add, the endovascular equivalent of what you did by observation in the temporal M2 it would be if you were to place a microcatheter into the aneurysm and see that, you know, the temporal M2 was coming off right at the area where you had the trauma, you can do provocative testing. So you can do intraarterial lidocaine and Brevital and test the vessel as if you were to deconstruct it. So let's say you coil the aneurysm and the area of injury, and your M2 shuts down. Sometimes it may, sometimes it may not. If the patient passes provocative testing, then you could have treated minimally invasive as well.
But Stav, I mean, I know you know that provocative testing is not an exact replica of sacrificing the origin of the vessel, correct? You're showering, you know, the brevital into functioning brain that may be getting collaterals from the PCA. You know what I'm saying?
So you have to be just within that vessel. If you say, if you see collateralization, obviously it's a false pass. Right. And there's also a 20% false pass in every provocative test, which unfortunately it's not 100% proof.
Right.
That would be the endovascular equivalent of what you observe.
But I mean, seeing this whole, I would think endovascularly would be very tenuous, but I don't know, you know. So anyway, she did perfectly.
Great case.
Yeah, interesting, huh? These holes, little things. Eva, was there anything else? Yeah, that's a post-op.
This is the post-op imaging.
No. I think the equivalent of this is the times for dissecting aneurysms, the things that seem to work are flow diverters. So if you were going to sacrifice it anyway, maybe that's the treatment where you put a flow diverter in the healthy vessel.
Well, you know, we discussed it, of course, as a team with my endovascular partners, and no, I mean, they agreed that surgery is the way, you know, they did not want to try endovascular, at least at our place. Okay, and then maybe a quick case that David, our current fellow, can present, get your opinion, and then I'll let everybody go and enjoy the evening.
Sure. Can everyone see my screen?
Yes, you can.
Okay, great. Well, thank you again, Dr. Morcos, and it's an honor to be able to present to accomplished panelists today. So this is a challenging case that we saw in clinic earlier in the week. 18-year-old with an acute onset headache, vomiting, neck stiffness last month that resolved after a week. She visited the emergency room and was sent home, and then saw an outpatient neurologist who obtained an MRI. And her exam, she was neurologically intact. Here's her MRI performed as an outpatient. And you can see this midline vascular lesion and associated potential aneurysm here. So an AVM with a perinatal intranidal aneurysm is the presumed diagnosis at this point, and she subsequently underwent an angiogram. Left and right ICA injections, and you can see the aneurysmal formation. Dr. Morkos had some thoughts on the exact diagnosis and how to classify that that aneurysm. But I'll turn it over to the panelists to discuss what their thoughts are on management at this point.
So if I, thanks, David. If I can add, I was pretty I just saw her a few days ago. I was pretty convinced she had a small bleed on November 7, and nobody picked up on it where she went. She had even neck stiffness for about 6 days and then recovered. Still has, interestingly, some nausea. No, keep your slides on. I'm sure you're going to go back, David, to some of the images. Judy, you gave us a spectacular analysis of AVMs. Mm-hmm. Just describe to us, what you see, how you interpret her risks. What is it? What kind of AVM is it? What's this?
Right. This is very challenging. This is even though it's small, it's exclusively deep. The ACA feeders, look like they're incredibly small vessels. There's no, I don't see a major,
right
branch, and it's the only good thing about it is that the nidus is pretty compact, I think, and instead of diffuse. That's the only favorable thing about it. The outflow is very interesting to me. There does look like venous stenosis outflow, and then that sort of the hang up of the stasis in the outflow.
Yes.
Is very bizarre. So this is not a good case for microsurgical resection in my mind. I think it's very hard to reach. It's a long reach. I was thinking about, if you were to do interhemispheric or something like that, but that looks very challenging. So I do think, I'll defer to the others for endovascular, but I think it's something that's more suitable for radiosurgery. And I would say, did you do any Dyna CT images to try to get axial imaging for sort of targeting? That's what we would do here.
You're not worried that radiosurgery will be a 2 to 3 year wait?
Oh, I am totally worried. Yeah, no, I think it's but I
yeah,
no, it's not great. She doesn't have good options.
Stav,
can you show the MRI again real quick, please? If you can show me the nidus and the MRI.
By the way, you can see two circular things on the axial MRI. What I think is a venous varix, but also a trapped frontal horn. It's white on CSF. The left frontal horn, interestingly, it's trapped here on that bottom right. There, you see that? CSF, mm-hmm. Interesting. So it's blocking foramen of Monroe on, I'm sorry, on the left, I mean.
Yeah, then, so if you go back to the angiogram, the nidus, like Judy said, it's racemic, so there's really no good arterial feeders. This is not an endovascular candidate. The slow filling aneurysm, it's a venous aneurysm, so it looks like most of those feeders on the MRI are actually relatively anterior and less steep than the outflow. Radiosurgery, like Judy said, it's a great option, but if there is a history of hemorrhage, with which Jacques, I think you said you think she had a sentinel headache.
Yeah, more than, I mean, she had neck stiffness for 6 days and nobody did a scan. It
Yeah.
sounded like a small bleed, I would say.
Yeah, I think that microsurgery would actually be her best option, and at least attempt to do a nidus resection and skeletonize and remove that that nidus. Obviously, hopefully the venous aneurysm, once you occlude the nidus, would just go on to regress and you won't have to worry about placing a ventricle or a shunt. But yeah, minimally invasive options, not great here.
I guess you're right. You could come subfrontal. I think that there's a little risk. I worried initially about the risk of residual.
Yeah.
You know, so there seems to be, it crosses the midline. You know, there's these wispy vessels that are further out.
And obviously bifrontal, bihemispheric injury, but I think the alternative, it would be 2 very long years to wait on this.
So Stav and Ali, our good friend Henry Wu is in the audience, and he wrote, besides wishing me happy birthday, which is my birthday today, he suggested a transvenous embolization pressure cooker. What do you guys think? You guys who do this, what do you think of that?
The patient will become a pressure cooker afterwards. I think that I'm sorry, stop. Go ahead. I didn't mean.
No, go ahead, Ali.
Please. After
So,
you.
Yeah, the issue here with the pressure cooker, and for the non-endovascular folks in the audience, it's basically described a lot in the European literature. René Chapeau is a very famous interventional radiologist that started it, but it's basically occluding the aneurysm via transvenous route while shutting down arterial inflow and controlling the aneurysm that way. It works well with deep AVMs such as this one, and with AVMs that have a single venous outflow such as this one. My concern for that is you know, the large venous ectasia there, whether you would be at a higher risk of rupture navigating through that. B, there's venous outflow stenosis that we saw in the dynamic run. And C, whether we would be able to actually flow arrest. I'm not sure we have large enough feeding arteries to be able to safely, I don't have the contralateral injection.
I agree with you, they're small. It's like
so I would be very hesitant to, you know, to flow arrest from the arterial side so you can do the pressure cooker from the venous side. Great suggestion though, because of the deep location and the single venous outflow, but I would be very hesitant to do it. And again, like we said, microsurgery option is still there.
Well, that's what I offered her, and I offered her a super selective angiogram just to understand the nidus better. But she is getting a couple more opinions, and obviously I just saw her this week, so I thought it's an interesting one for conversation.
I think there would be a utility in repeating the angiogram in a delayed fashion. You know, after she resolves her hemorrhage, I think there's a possibility that you'll see more vessels that you're not seeing now. And, you know, that might inform the microsurgical approach.
Was there hematoma, Jacques, at the...
No, there is no hematoma. No, there's no hematoma, Judy. It's just a small subarachnoid.
That was all the...
Is it in the hypothalamus or in the fornices from the MRI?
It's really the anterior perforator substance. It's not a fantastic area to operate, but that's where anterior perforator substance.
Yeah, this concept of venous occlusion is not a new concept, as you all know. It was initially described by Sean Mullen, who was a surgeon, would measure the venous pressures, take down arterial feeders and then close that off. I think without really understanding the hemodynamics, to take that type of approach, I think renders a lot of hemorrhagic risk. So for me, depending on the eloquence of where this actually is, it's either a surgical case in good hands or a radiosurgery case in mediocre hands.
Okay. I'm sorry, I'm gonna have to cut you guys short because I have to leave.
Happy birthday,
you.
Jacques.
Thank you
Thank
so
you.
much. I cannot say this was
Birthday.
a fantastic session. Of course, I have excellent taste in choosing my speakers, and here is the proof. Thank you all. Lovely
Thank
to
you.
see everybody. Thank you for the audience, to the audience for sticking with us, and Happy New Year to everybody.
Thank you.
Thank you.
too.
Thank you very much.
Happy birthday.
Happy
Have a
holidays.
great night.
Thank you.
Thank you, guys.
Thank you.